AI is a powerful tool.
This summit can help ensure that artificial intelligence charts a course that benefits humanity and bolsters our shared values.
Welcome to AI for Good, the leading action-oriented, global and inclusive United Nations platform on AI. Organized by ITU, in partnership with 40 UN sister organizations, and co-convened with Switzerland. The goal of AI for Good is to identify practical applications of AI to advance the United Nations Sustainable Development Goals and scale those solutions for global impact. In today's session, we're counting on you to use the live video wall feature to ask questions and post comments to help create an engaging discussion. We encourage you to stay until the end to chat, connect, ask questions, and network with our distinguished panelists and world-class AI experts in the neural network. It is now time to kick off the session and welcome our first speaker. The floor is yours.
Hi, everyone. My name is Harrison, and I am a researcher at Harvard Medical School, and I will be moderating our webinar today. So our team is really excited to have everyone joining us, and we have organized really an all-star lineup of speakers for the 2023 webinar series in AI for Health. To kick things off, we are really lucky to be joined today by Ao Kong and Xiaoshan Liu. So just some brief bios about our two speakers today. Ms. Ao Kong has 17 years of international management experience in global strategy, technology for peace and development, and multi-sector partnerships working for the United Nations. Recently, she has took on a new role in the UN Development Coordination Office as lead for private sector engagements. Ao also serves on the MIT Solve Annual Challenge Leadership and Judge Panel, where she guides tech-based social entrepreneurs to solve world challenges. She is also a featured speaker and writer at global events, including the Milken Global Conference, the Harvard Business Review, World Economic Forum, and IEEE. Our second speaker is Dr. Xiaoshan Liu. He is the Asia Chair of IEEE Entrepreneurship, the Autonomous Machine Computing Chair of the IEEE International Roadmap of Devices and Systems, and a member of the ACM US Technology Policy Committee. Dr. Liu's educational background includes a master's in biomedical engineering, a PhD in computer engineering from the University of California at Irvine, as well as a Master of Public Administration from the Harvard Kennedy School. Our speakers will talk today about expanding access to essential health services to hard-to-reach populations with autonomous clinics. And Ao and Xiaoshan, please take it away.
Hello, everyone. I'm Ao Kong. I hope you can hear me clearly. It's a great pleasure to be here together with Dr. Liu. Today, our topic is a very special and essential category within artificial intelligence, but also within international development realm, which is to do with affordable universal healthcare access through automobile clinics. And these automobile clinics also are equipped by, artificial intelligence, technology, and hardwares. Today, as you can see at the bottom, we also have our blog post, which was already shared with the AI for Good community. You can see some of the basic concept we already published over there. Also, throughout the slides, we're going to show some of the other publications we did with the World Economic Forum and with IEEE, both covering the development side of importance of this technology and thinking, as well as the economic benefits and development benefits for all. Without further ado, I'm going to go to the outline for today. So here's the sequence that we're going to through. I'm going to start by introducing the SDG 3, the UN Sustainable Development Goal number 3, and the concept of a universal health coverage, the vision, reality, and challenge. Then I'm going to go through the implication of AI to health equity very briefly. Then I'm going to touch base on the experiment that I started with Dr. Liu in my capacity formerly as the Chief of Resource Mobilization and Partnerships, as well as Senior Program Advisor for the UN Technology Bank for the least developed countries. Then I'm going to pass on the floor to Dr. Liu to cover the specific application of the automobile clinics with the AI doctor functions. An example, we're going to be given on the monkeypox detectment, and some of the technical details on the key enablers. At the end, we're going to discuss a little bit on the expansion of this concept and application into the development sectors and technology realms. Then, of course, the floor will be open to engage discussions. As mentioned, because of my role and background with the United Nations and development sectors and investment sectors, I will focus on the discussion. I will focus the discussion around the usage in the development sectors, especially for AI technology and its implication to health equity. And Dr. Liu will focus on the real design of these projects. And then we want to engage your communications and interactions on what are the areas we can expand to in all kind of, geographical contexts, agent contexts, and also diseases contexts, and engaging more scientists and technology practitioners in terms of implementation. Okay, next slides. So first, I'm going to start by I mentioned the Sustainable Development Goals of the United Nations. I hope most of the audiences are very aware of them. So today, specifically mentioning the SDG 3, which is ensure healthy lives and promote well-being for all at all ages. That also linked to the universal health coverage concept. In September 2019, the heads of states and government endorsed this ambitious and comprehensive political declaration at the UN General Assembly to say that the universal health coverage is the right to every human being without distinction of any kind to enjoy and attain the highest standard of physical and mental health. This is not only a human rights issue, but also an enabler for health, for healthy population and productive population to actively engage in social activities and actively engage in producing economic wealth, participate in building a sustainable society. So as we know, without health, everything is a foundation for health is foundation for everything. Today, I also want to pivot the topic just for 1 minute, as I recently returned from Turkey, and probably most of you have heard about the devastating earthquake. It actually, really gave me a very heavy mode, as it was a land that I lived in and worked on, but also related to today's topic, thinking about how technology and development realm and also humanitarian assistance can work together, utilizing the latest technology and thinking to see if we can use more robots or, mobile clinics together to alleviate the pain caused by pandemic, crisis, earthquake, so on and so forth. So I think the urgency here is, it goes without speaking. Now, let me continue. So this year, we're also going to have a high-level meeting in the United Nations, kind of going through or reviewing the universal health coverage challenges and opportunities. I understand among our audiences today, they are health practitioners and technology professionals who are very dedicated to provide health equity for all. I encourage you to check out the UN website to see and engage in the dialogue on universal health coverage and see what we can contribute together. Why is universal health coverage suddenly brought into the agenda? I would say because the reality is relatively dire. Not to mention the aftermath of COVID and the heavy toll on health and also on societies in general. Just to say at least half of the world's population lacks access to essential health services, and still up to a third will remain underserved by 2030. I'm going to discuss quickly about the underserved concept. But today, I want to mention that the concept of the automobile clinics and what we try to do is really to reach the underserved, and the underserved could include emergency delivery of babies, including refugees and displaced population, such as after disasters, earthquake, and wars. As you know, these kind of incidents are increasing in the world today. They're hard to reach. A lot of them maybe live in remote area. It could also include an aging population, which is also a prominent issue, not only within, fragile states or humanitarian settings, but just in regular societies. A lot of countries are facing aging population issues with shrinking young population who are taking care of the old generation. So the automobile clinics are being tested in many countries to see if they can perform some of the basic functions of picking up people, doing the basic test, and hopefully with more AI development, as we're going to mention later, will perform more complex tasks through machine learning. So in conclusion, these are the technologies we want to use, specifically its artificial intelligence learning functions to allocate resources to meet more demands and meet complex demands as the humanitarian and development needs growing. Next page, please. Just want to quickly touch base on the implication of artificial intelligence to health equity. Number one, I think we're all familiar with the discussion in terms of what would artificial intelligence replace human beings in terms of what functions and what are the essential roles of humans. We also recently going to have a new task force, or let's say brainstorming platform within the United Nations to talk about the chatbot and its implication to diplomacy and to societies. But I want to mention quickly today that in my opinion and research, the artificial intelligence, number one, there are two essential points. Number one, they take your order to perform a specific task, and they can perform the task very well, number one. But that also means that the tasks and the directions should be set by humans, especially in the very complex situation. In another sense, in terms of health equity, we have very limited resources for doctors, for nurses, for the health practitioners to examine the overall situation at the micro level would be, what would the diseases be, giving connection to a patient's history, versus at the macro level, look at what are the general population needs, how does the Ministry of Health, allocate the resources, giving consideration into different contexts and competing priorities of a country, of physical situation, of allocation of resources. So we want to engage or prioritize these kind of resources into setting directions, making decisions on complex tasks for the doctors to free their hands to focus on the complex and essential diseases versus allocate the artificial intelligence to perform very efficient execution. This will be explained later in this PowerPoint on how we're trying to use artificial intelligence or these mobile clinics to perfect certain tasks that already have very prominent criteria or prominent features to diagnose. This is one of the first extinction. Number two, as also quickly mentioned, one is for human beings to tell the complexity in real society application at different levels will link to either, for instance, for pandemic, link to policy making, link to considering its damage or damage control on economics versus prioritize safety and health for all. These are the trade-offs, the big trade-offs in society. And for patients as well, when a patient with complex history have to choose the medicines or treatment to use, how do we balance the benefits and side effects on treating certain patients? These would need more discrete judgments by health professionals versus artificial intelligence in terms of health equity can be better at pattern recognition. There were projects, for instance, I worked before in Tibet, in China, also using mobile clinics to detect certain infections of parasites of people. These are very heavy task examinations that required tons of doctors that would, really squeeze medical resources in Tibet. But with pattern recognition and image scanning, the patients with certain parasite infection have very prominent expression through their skin and through their organs changing shapes that can be immediately detected by outside pattern recognition. So these would actually perform the first diagnosis and pass on the either the prescription of medicine or follow-up to the health systems, but can free essential resources. So essentially, as I see, technology in development can reallocate resources to the most needed, especially for human beings playing the tasks that cannot be replaced or cannot be streamlined by technology or artificial intelligence. And also, it's a powerful tool for both economical issues. As mentioned, a lot of economic issues boil down to resources versus demand, and also rights-based issues. The rights-based issues, meaning access to healthcare, to basic treatment of diseases, also rely heavily on what resources available and access. Even with abundant resources, without access, for instance, the people living in remote area, we have a big displaced population, for instance, now in the Sahel region. How do we provide services to these population as they migrate? And we'll talk about in the future, maybe there will be more climate refugees because their countries are not in the livable conditions anymore, have to move to other new locations. How do we provide medical access to them and health access to them? Can the AMCs, the automobile clinics, follow through the populations and collect essential data and perform basic diagnosis? I think this can be discussed. further. Finally, in terms of application, as we can see in most of the artificial intelligence application cases, it requires collaboration across sectors. So one of the discussions I had with Dr. Liu and with different governments is to see how do we align policies, regulations, as well as technology, protection of data, safety, better utilization of data, as well as the United Nations assistance, guidance, strategic thinking, and coordination across sectors and within the United Nations to provide a comprehensive package so that AI and technologies can be utilized and better utilized for the best development section. Also, the exciting part of application would be in various contexts. As mentioned, they are hard to reach population, they're underserved, including people who are hard to reach, but also with limited resources, aging societies that also exist in very developed economies. So the application of these AMCs are very exciting in various contexts. So next slide, I'm just going to quickly touch base on how we started the project. When I was the senior program advisor and chief of resource mobilization with the UN Technology Bank for these developed countries, our focus is on detecting the cutting edge technology, innovation and science, and to see how we can apply them in the least developed country settings. The LDCs, 46 LDCs in the world, and majority of them in Africa, some of them are in Asia. And we also have a couple of islands countries, are the countries with the social and economic barriers to advance their economy and social well-beings. But we also recognize that with the development of new technology, not only artificial intelligence, but also, let's say, mobile phones and e-commerce and so on and so forth, also provide leapfrog opportunities for developing economics and least developed countries to utilize something new, adopt something new to see if they can be served better and utilized to benefit bigger population. So me and Dr. Xiaoshan Liu discussed to see how these mobile clinics with AI doctor functions can be used in least developed country setting. So through our brainstorming and feasibility study, we deemed that, for instance, there are a couple of countries we can pick in the LDC settings to test these AI doctors, picking one or two very prominent indigenous diseases, for instance, with a prominent expression that can be easily detected by artificial intelligence doctor diagnosis, and then transfer these data initial diagnosis into the bigger health system for further treatment and follow-up. So this concept was very welcomed by the World Economic Forum and was listed by as one of the agenda items. From this example, we realized that, for instance, next page, we also pitched and discussed the concept with the World Health Organization and published these preliminary research and thinking through the bulletin of WHO. As for most of the new concept, we need to, through more experiment, to collect data and to see what are the quick wins for these cutting edge technologies, but also for countries and for policymakers to see where the gaps are and how we can develop a system that better process data, collect data, protect data, but also have health policies, for instance, sending these automobile clinics to different areas and allocate these resources properly. So that was the beginning of this collaboration to combine the development sector and technology sector to explore potentials. The good excitement, the exciting developments which would be introduced by Dr. Liu right now, is that there are more experiment and test performed based on, for instance, monkeypox, and thinking and detecting about other infectious diseases that can be used, and also thinking through different developing contexts where the mobile clinics can also be deployed, taking into consideration of the local culture, the road situation, and so on and so forth. So I'm going to pass on the floor to Dr. Liu to go through the technical details.
Well, thank you very much, Audrey. In this part of the talk, I will focus more on the technical aspects of our project. I personally came from technology background. In the past decade, I focused on AI and autonomous driving, and a lot of the content are based on scientific research that we conducted. So the first research we did was in collaboration with Johns Hopkins Bloomberg School of Public Health. We study what's the health management benefits of autonomous mobile clinics. So from the previous slide, you could see that autonomous mobile clinics, they are pretty much self-driving vehicles that are equipped with different medical equipments so that they can go to the patient when needed. And the nurse on board would be able to perform some basic tests, and then would be able to connect to a remote doctor through telemedicine, especially as Al mentioned, for example, in Turkey, when there's a disaster that hits, autonomous mobile clinic would be extremely helpful. Also for the hard-to-reach population and the underserved population, AMC, we think it's revolutionary technique to address these problems. So what are the basic public health problems that we see? I think there are three basic challenges. The first challenge is access itself. People are often denied access to healthcare services for many different reasons. Lack of mobility, particularly for the disabled and elderly population, unpleasant user experiences, especially for countries with overloaded healthcare systems. And then we believe that the AMC effort can solve these problems. The second challenge is equity. While mobility enables access, it does not guarantee equal access. The reality is that healthcare resources are often unevenly distributed, and this distribution is often strongly correlated with the wealth distribution. So equal access can be solved, for example, through AI doctors or through telemedicine. The third challenge is efficiency. Often there's a supply and demand mismatch in healthcare. You don't have enough doctors, you don't have enough medical resources to serve all different people. And often these resources are unevenly distributed. For some certain rich regions, you can have a lot of medical resources, but for other regions, you may not have that much resources. Then how to solve these problems? We think a three-step approach would be able to help solving this problem. The first stage is to develop the AMC autonomous mobile clinic platform to deliver basic disease screening, and the vehicle would come to you equipped with the basic equipment to conduct tests on site. But that only solves the access problem. Then next question is, how do we maximize efficiency? How do we minimize cost? I think AI is here to help. Most of the AI doctor can do most of the disease screening, especially, for example, monkeypox or other contagious diseases. And with these two steps done, then we go to the ultimate step, such that we go into different AI medical verticals. In that case, the AMC clinic can be converted to different medical verticals. So those are the steps that we envision. And regarding health management benefits, that was done in the paper that I just shown. First of all, it's an optimal medical resource allocation because the AMC can go to the patient and then connect with doctor through telemedicine, such that the patient do not have to wait in line, wait for a long time to get healthcare access. Cost reduction, that's quite obvious because you have AI doctor performing, say 90% of the job of the primary care doctors. The cost would be very low because AI doctors can practically serve unlimited amount of patients. And the third benefit, it's very interesting one. It provides affordable medical training, such that with AMC, students can pick up new skills to conduct medical advice through telemedicine, to operate the POCT equipment on board. So there are some quite interesting health management benefits aside from helping the underserved and unreached. So how do we do it? Automotive industry is traditionally not connected to the medical industry. One thing that's quite interesting in automotive, there's something called the domain controller, which is the central computing unit within the vehicle. So to enable different kind of AI applications or medical applications on a vehicle, you need to define a new domain controller. And that's the main technical challenge to bring healthcare services onto vehicles. For instance, for autonomous driving, usually in today's car, you have a autonomous driving domain controller that's in control of all the computing required for autonomous driving. And then for smart cockpit, you would have a cockpit domain controller to deliver the entertainment services. But health domain controllers, it's quite new and quite innovative. And we believe that technology is the key innovation to enable AMC. So as we have mentioned before, eventually AMC should be configured to different medical vertical to deliver different kinds of medical services. But we start with primary care. To start with that, we need at least 4 basic capabilities within a vehicle. First, we need to integrate different kinds of medical equipment within the vehicle. Then autonomous driving is necessary because it helps to navigate through different scenarios, whether it's a city or it's a disaster site. You need that autonomous navigation capability. And then you need telemedicine to connect the patient to a remote doctor. At the end, you need to keep track of the electronic health record that's related to the patient's privacy. And what's not mentioned here, which is very important, it's the AI doctor capability, which is the main topic of today. But what can already be done in a car in terms of healthcare? There are various kind of sensors that are in the process being installed in commercial vehicles today. For example, millimeter wave radars that can measure your vital signs, IR cameras, RGB camera that can help measure your vital signs, thermal cameras, they can measure different parts of the vital signs. Photoelectrics, conductive textile, wearable devices, all these combined would give you a very comprehensive measurement of a patient's vital sign. Then for some of these cameras can do facial expression tracking, such that they can track your emotion, check your behavior to see if there's anything that's abnormal. Then for more advanced sensors, for example, some thermal cameras can even measure whether you have the potential of having a stroke and so on and so forth. So the existing sensors are already able to measure different aspects of your health conditions. By integrating all these sensors together, will give you a very comprehensive view of this patient's condition. For example, in the past 5 years, you've seen Apple devices start measuring more and more of your vital signs and different health conditions. But that's just one piece of wearable device. But imagine that you're in a car. The car can be equipped with a lot of various health sensors that would provide you with very comprehensive data. And then because you have enough space in the car, also you can spend enough time in the car. So instead of a very single data point measurement, we can provide comprehensive data measurement within the car. I think that's the beauty of autonomous mobile clinics. But what needs to be done if we dig deeper into the technical areas? It's a health domain controller, as we mentioned. Here is a hardware architecture of that health domain controller. First, you need a very well-defined I/O interface, such that it can be connected to various kinds of equipments, medical equipments. Then with that, the data would be routed to an AI health engine. The engine has to live on board so that the patient's data does not have to leave the car. That will reduce the privacy concern from the patients. And we need encryption to store the health data. Also, we need connectivity to different kind of remote doctors. But connectivity is very unstable in the real world. So we need multi-model connectivity capability such that you can have 5G network, 4G networks, even satellite internets to connect to that remote doctor. So this is really a key innovation that has to integrate many pieces of technology together to enable AMC. To dig further, if we look at telemedicine, which is key feature in autonomous mobile clinic, one of the key problems we see that is in various regions of the world, even in advanced economy, different kind of cities or rural areas, connectivity is very unstable. It fluctuates a lot. So that does not guarantee that you can have a stable connection to your doctor, especially when you are sending very large files. For example, your CT scan through the air, then you really need this multimodal connection capability to guarantee that you have a stable connection. And that's a key research area we are pushing towards as well. So one of the key or the most important feature on a AMC is actually the AI doctor. But before we migrate the AI doctor onto the AMC, if we can run these AI doctors on mobile phones, we could immediately help a lot of the unreached population or hard to reach population. For the fact that a lot of people, even though they do not have a very good healthcare access, most of the people have a piece of cell phone, a smartphone, even it's a low end, less than $100 smartphone. If we can infuse that AI capability onto the smartphone, it would be able to provide immediate help to these people. And that's the aim of the project, ACOM or AI Clinics on Mobile. Our goal is to provide that healthcare, basic healthcare capability on even the lowest, cheapest smartphone. So a lot of the AI capability are deep learning based. The key questions becomes how to compress a deep learning model to make sure that even it's a very low end form, they can still run these kind of applications. And that's the key challenge. Fortunately, in the past 10 years, we have been doing a lot of research in this area, starting with this effort titled Enabling Deep Learning on IoT Devices. Usually IoT devices are very low-end devices with very limited compute power. But by using the basic operators on these low-end devices and map these operators onto even basic deep learning operators, we can optimize this network so that they can run on even a $5 computing chip. And this is the work we have done in 2017. It's manual optimization to move different models onto a IoT device. Then later on, we have the technical compression, compilation, code design, such that the compiler will be able to automatically map a deep learning model onto a off-the-shelf mobile devices. These are the sequence of work enabling technology that enable us to run mobile applications or health AI applications on very low-end mobile phones. Monkeypox. In the past year or so, we have seen a global monkeypox outbreak, and even a lot of people in, whether it's in LDCs or the global unreached or underserved population, they're facing this problem. But monkeypox, it's fairly easy to perform screening on because the symptom of monkeypox is very obvious. But if you are not a medical professional, you have no way to judge whether you have contracted monkeypox. So a very straightforward way to solve this problem is to implement a monkeypox screener on a low-end mobile phone. So that's been ACON's first project, it's ACON monkeypox or ACON MP. Basically, we have developed a model, a vision-based model. We have fine-tuned it against various data sets such that it now has achieved the state-of-the-art result. And then we also have performed a lot of optimization to move the whole model onto the phone. So we have made two contributions in this project. First, we develop a network that's able to accurately detect and screen for monkeypox diseases. Second of all, we have collected a lot of data and open source the data set so that if people need further improvement on that, they can utilize either our source code or our data set. And both the source code and the data set has been open source, so that anyone could utilize this and integrate this into their own services. And that's been the philosophy of our project. We open source everything that we developed, and we open source all the data as well as source code as well. So we have a hosted website. It's a very simple steps. You upload a picture. Say you can take a picture of your skin. You upload the picture. Then the engine will help you to perform monkeypox screening to tell you whether you probably you have contracted monkeypox or not. Here's the open source GitHub page so that anyone can access this data and the source code for this AI doctor. But besides monkeypox, we believe we have found out a methodology to move different kind of health AI models onto mobile phones. And we intend to develop a application, a health AI application to screen for different kind of diseases and to treat for different kind of diseases. And in the future, we will release different version of mobile apps that's running on various low-end Android phones. And with the help of United Nations, we hope to distribute these applications to people who need it the most. Because according to our study, most people, even those unreached or underserved, they have a mobile phone. And the beauty of our application is that it does not have to connect to a cloud server. It runs on the device, such that if the patient is concerned about his privacy or her privacy, the data does not leave the phone. So that sort of concludes our work. It's still in the early stage, but we believe that AMC is our ultimate vision. But as a first step, we can provide immediate help through developing AI doctors that run on very low-end phones. And that's been the goal of our project. At this time, I would like to thank a few of our collaborators, especially Team Yang and Tom Yang. These two are brilliant undergraduate researchers that have been working with us in the past year, pretty much developing the AI application from scratch. So if you are looking for graduate students to perform medical AI research, these are the key guys that you should recruit. Then we have Dr. Anna from Harvard School of Public Health. She provided the public health advice and medical expertise onto a project. She just gave a talk, tremendous help on the vision. Professor Steve Liu, he's the professor at the McGill University developing the AI technology. Jitang, she's a professor in China providing the embedded system technology for us. And Andrew, also a brilliant intern that's been working with us on various AI techniques. So with that, I would like to hand the stage back to Al to provide the concluding remark.
Yeah, thank you all for listening to our presentation today. To conclude, number one, as we dissect the package, I think we touched on three concepts. Number one is in the development context, how does technology and development work together to provide health equity for all? So that's in the development realm. Number two is mobile clinic. So it's basically how do we streamline and maximum the usage of mobile clinics. And the third concept is AI doctor. How do we really maximize or utilize the artificial intelligence function at this stage, mostly in diagnosis, but hopefully in the future can perform more complex functions and also combine diagnosis with more prescription functions, taking into consideration of bigger data of the patient's history. So through my role at the MIT Solve leadership, I did look at their different also designs of mobile clinics. Some of them are even on the motorbike that can go to rural areas at very low cost because it's a low cost design, it's low cost manufacturing of motorbikes that has also stabilizing functions, so they can go through very difficult roads and situations and reach hard to reach areas. Then combining with artificial intelligence to detect diseases, you can really multiply the function. Third, when we look at from the development point of view, how do we design a health system that can maximum the benefits of technology and artificial intelligence? For instance, a lot of townships or communities start having kind of a resident physicians or nurses or midwives that can help with the delivery. So when these mobile clinics come, they can probably help on the site to mobilize or coordinate on the functions of the mobile clinics, and also direct the patients for the next step, especially in the remote areas where patients need more instructions and handholding for next stage of their treatment or follow-ups. So hopefully our discussion can motivate your thinking around improving the mobile clinics access, improving artificial intelligence in health equity, but in other areas as well, and in the development context. So our joint call for action is, number one, try to pick your brain to see what are the other contexts or situations that we can use AMCs and better develop artificial intelligence. Also, who are the collaborators that can work with Dr. Liu to really improve the technology in terms of its own, improve the function, but also maybe funding, maybe experiments in more context. Number three, in my role, leading private sector engagement for the resident coordinator system, will also welcome more private sector and academia collaborators to think about where and which area and what countries they would love to contribute to the sustainable development goals and reach bigger impact with multi-sector collaborators. So over to you.
So Harrison, I believe that's the end of our talk. So we hand back the stage to you.
Yes. So I just want to thank Ao and Shaoshan for that incredibly inspiring and very, very exciting presentation on all of their work so far. We are, it's a really exciting application area of AI into an increasingly relevant issue of health equity. So now we're going to move our event into the question and answer portion. For the audience, if you have any questions, please put them into the neural network and we will make sure that we communicate your question to Shaoshan and Ao. But just to get us started, I have my own set of questions that I'll entertain you guys with first. And I guess I have one more technical question that I'll ask Shaoshan. So you mentioned that there's basically an almost inherent trade-off that you have to consider, i.e., we can develop really complex deep learning models that will require computational power, but since we are putting it on a more deployable and a mobile device, that computational power is limited. So could you kind of elaborate a little more about that technical trade-off there and how we might be able to find kind of like a sweet spot that hits all the requirements that we want to?
Yes, thank you for the question. I think it's a great one. We know in the past decade, machine learning, especially deep learning, has progressed quite a lot. People have generated even larger and larger models to perform more and more complex tasks. But at the same time, I think the systems research has progressed a lot as well. We have seen techniques of such as compiler design and different kind of compression techniques that can greatly reduce the model size. So, for example, one of the work that we have shown, the CocoaPi design has been able to automatically compress a network to run on very low-end devices without much sacrifice on the detection accuracy. And mainly these compression techniques can be applied for CNN type of neural network. But with the recent advance of ChatGPT and so on, I think those are large models. We still have a long way to go to try to compress those large models to run on a very low-end device.
Awesome. Thank you so much for answering that. I had also a little bit of a different flavor of a question, and I guess it's for both Ao and Xiaoshan. This is an incredibly exciting and promising area that is now emerging, and you guys are, doing amazing work in it. So I was just wondering, from your perspectives, if we think about scaling this up and bringing it to more different application areas and to more areas of the world to serve different underserved populations, what are some steps or big ideas that you think we need to take in order to be able to scale up this technology and to be able to implement it in a widespread manner?
You want to take this first?
Yeah, so for me to start mentioning, I think is to find a proper context or location, let's say, to experiment, because in reality, to cover large population, there are more complexity in terms of, for instance, logistics on how to organize these, mobile clinics. How do we have follow-ups? For instance, after diagnosis, how do we plug these diagnosis or results into a bigger health system that can, build archives for the patients, that can plug into the health systems so they can have follow-ups, they can have doctors who can access these records, and also maybe analyze that together with other health data. Similarly, even in a developed country, for aging population, how do we utilize this kind of technology that can cater to a lot of diseases related to aging population, have the mobile clinic to serve the aging, we call that aging economy, maybe that could engage more of the social workers to work in this case. Let's say if there's another lockdown due to another pandemic, how do we better utilize this kind of mobile clinics to its best? That also need to take into consideration the policies of a local context, the culture, sometimes to religions. So in reality, the application really need support of local government, local health system, and also to ensure its sustainability, plug into a larger system. For instance, if you don't have proper power plants, or the phone supplies is not stable, or the health system, any of them fall apart, cannot ensure the best quality of the results. So from the development angle is to see how we can have more experiments in different contexts, and what do we learn from, let's say, development point of view, from governors, from the policymakers, how do they better utilize and put the data and functions and access and everything together. So that would be a bigger chess game to provide experiences and data, maybe exemplary for other countries and other contexts. Over to Dr. Liu.
Thank you, Al. My answer is very simple. It's collaboration. If I hadn't met Al, for example, I would not know what's the best way to apply my technology, because she has the field experience of dealing with all different kind of situation globally. If you look at research paper-wise, if you say, oh, are there any very good medtech or health tech technology coming out? Every year, I think thousands of papers come out about how to apply those technologies, or first how to integrate those technology into a product and then connect the product to people. I think that's the missing link, and that's why we are here. Hopefully, in the audience, if you guys are interested in this type of work, we should join force to solve these big problems. Again, if I hadn't met Al, I could still conduct my research, but there's always a missing link there. How do I apply my knowledge, the technology, to help real people? I think that's what we all need. I'm thankful that United Nations ITU is organizing this event so that policymakers, researchers, engineers, entrepreneurs, they can all connect together towards the same goal.
Great. Thank you guys so much for that answer. I think that's a good way to go forward when you can't tackle all these complex problems. a lot of the times you need to reach across the aisle and form form relationships, with international organizations, with academia, with industry, and with different federal entities. So that's very, very inspiring to hear. We have a question from Jacob Brun, and he says, I have heard of drones being used to deliver medication and medical supplies to hard to reach areas. Have you guys considered kind of that route of delivery, and are you planning on using anything similar?
You want to take this one? It's I'm not sure whether United Nations is ready to use drones.
I think what Jacob mentioned is it's also related to health equity, but it's not necessarily related to artificial intelligence in this discussion, because we're talking about using image processing or big data to detect patterns that can connect to easy diagnosis of certain diseases and maybe going to more complex cases. And what Jacob is asking is related to the medicine supplies and which is not necessarily to do with using artificial intelligence. But I think there are a lot of private sector partners start using that technology to provide. So definitely, if you're interested, I think these are the areas that you can also look into.
You have to add to that, I think autonomous mobile clinic, the fact that it's a vehicle, it can integrate many different kind of devices and AI capability within the vehicle. So the patient, when the time that he or she steps into the vehicle, we can perform a lot of health screening, even telemedicine, to help him or her. But drones is more for logistics. In case you need to deliver food or medicine, you can use drones. I think we are solving very different problems here.
Great, thank you guys for that answer. I think we're still waiting on, we'll give everyone a few more minutes to see if they have any other questions, but in the meantime, I had a follow-up question for you guys. And I was considering the act of, delivering healthcare through these mobile clinics from the patient's perspective. So have you guys had any opportunity, or do you think it's important to be able to assess what the patient's attitudes or preferences are for this type of healthcare delivery, and if you foresee any type of pushback or in the contrary, like very much so acceptance of this type of untraditional way of delivering healthcare?
Yeah, definitely. I will answer this one. We have conducted a few pilot studies using autonomous mobile clinics. Basically, we have POCT devices. Using one device, you can check different vital signs and different measurements. Usually, the setup is we have a nurse on board to help the testing and health screening, and then we connected the remote doctor to the patient so that they can do medical consulting through video chat. I think that's quite smooth because of the fact that there's a nurse on board. We haven't tested the case that there's no one on board. I think at this time, it's not the best time because the patient, especially the hard to reach and underserved ones, I'm not sure they know how to operate those equipments properly. So that without some professional to operate those equipments, we are not confident that we will get very good results. So far the testing with a nurse on board has been very smooth.
Just to build on what Xiaoshan just mentioned, my experience is similar. Having a let's say health practitioner together with the mobile clinic is essential not only for performing the function, but also for trust, because most of the population are used to have a real person interaction, especially with someone they already know and trust, right? Imagine your grandpa in the village, and sometimes it comes this mobile clinic. They have no idea what does this do and what they can trust. But if it come with the community worker, even who they know, who the family has been interacting for years, it's easier for them to trust the person will guide them through the different process. Meanwhile, this person can also direct them for follow-ups, because as you know, in treating health problems, the follow-ups and lack of follow-ups, or especially lack of follow-ups, is an essential issue. So having a person on board to kind of make sure they take the medicine, make sure they do the follow-up checks is also very important.
Great. So thank you guys so much for providing that insight and for kind of touching on digital determinants of health, i.e., how technologically capable a person is and how that might affect how this care is able to be delivered. So I think that is all the time we have today for questions. I'd just like to again send a huge thank you both to Ao and Xiaoshan for giving us a really, really exciting presentation that shares their work and some of the mission-driven science that they've been embarking on, as well as giving us a really inspiring call to action that we should be thinking about as we walk away from the presentation. So Julian, back to you.
Thank you for participating in today's AI for Good session. We hope you've learned something new, innovative, and engaging in today's event. We now encourage you to continue the conversation on the live video wall in the neural network. Here you can ask questions, like and comment, share links, complete the poll, connect with interesting profiles, or speak one-on-one using the chat and video function. We invite you to explore the lobby, try the smart matching quiz, visit the virtual exhibits, poster boards, the eShop, and build your personalized AI for Good program. Let's shape the future of AI for Good.
AI is a powerful tool.
This summit can help ensure that artificial intelligence charts a course that benefits humanity and bolsters our shared values.
you.